Hello, everyone. My name is Abina, and today we have Dr. Arjun Masurkar with us, and he is going to give us a presentation on healthy brain aging. Dr. Masurkar is a physician scientist with a focus on the mechanisms, biomarkers, and therapeutics related to early Alzheimer's disease. Dr. Masurkar received both his MD as well as his PhD from Yale University and completed his residency and fellowship at Columbia University. At NYU, Dr. Masurkar wears many hats. He's an assistant professor of neurology and physiology and neurologist at the Pearl Barlow Center. He's also an investigator at the Neuroscience Institute and the clinical core leader of our Alzheimer's Disease Research Center. So I will turn it over to Dr. Masurkar. Well, he will give his presentation now.
Well, thank you so much, Abina. And Abina, you can hear me, right?
Yes, we can hear
Okay,
you.
great. And yeah, so it's my pleasure to go over this very important topic of healthy brain aging. And I'd like to give this talk really with two objectives. One, to understand healthy brain aging, I think it's important to understand how the brain works to some degree, specifically to understand what memory is and what it's not. And secondly, in talking about healthy brain aging, to appreciate the various fixable and non-fixable factors that impact brain aging, both healthy brain aging and even pathologic brain aging. Just to the right, if you're not familiar with the pictures in the upper left is Dr. Alzheimer, who described the disease that bears his name over 100 years ago. In the upper right is the patient, August Dieter, in whom he described the disease. And below is a cartoon representing the principal pathologies of Alzheimer's disease. You can kind of see this triangular shaped brain cell or neuron that is presumably encapsulated by a tangle, the tau pathology of Alzheimer's disease. And below that cotton ball appearing thing is an amyloid plaque, which is the other principal pathology of Alzheimer's disease. So as I mentioned before, in terms of our objectives, I will also, have the following agenda. For the first part of this talk, we'll talk about how the brain works, the science of memory, and secondly, how the brain changes with aging and what to do about it, i.e. the medicine of memory. So I often use this analogy when speaking to patients and families about memory. It's the office analogy. Memory is a process by which knowledge is encoded, stored, and later retrieved. So in terms of thinking about an office, the encoding part of this is sort of assembling a file with the information that's critical to recall later. The storage is putting it in the appropriate place in the file cabinet, in the memory storage location. And the third part is retrieval. It's being able to go to that file cabinet in an efficient manner and get the file back out. And we do that all the time. We do this thousands and thousands of times every day, and we don't even realize it. We take for granted how much we rely on this process. However, memory is only one aspect of cognition. There is attention and concentration. There's planning and organization. There's language, and many others. And they're actually all intertwined. None of these processes are happening in isolation. Moreover, there's different kinds of memory. Of course, you can divide memory into those things that are short-term, things that you are supposed to recall from a few minutes or maybe from yesterday. And then once we're talking about things that are weeks, months, or more, that is deemed more of a long-term memory process. In turn, even long-term memory can be divided into memory for facts, people, places, and things, and that's called declarative memory, as well as non-declarative memory. These include procedures like riding a bike, Associative learning, the classic one is the Pavlov's dog, where you can train a dog to associate a ringing bell with food, right? And non-associative learning, which is sometimes even getting used to something, learning to get used to something, like this woman who's reading in the park, and she's getting used to, with time, the ambient noise around her, the dog barking, the man on his cell phone, the helicopter. One can also divide short-term memory into these same things. There's short-term declarative memory, remembering the name of the movie that you just saw last night, right? Remembering the name of that person who you met at dinner at that restaurant, for example. We've also discovered through decades of scientific research that each kind of memory, depending on the duration and depending on the type, relates to particular parts of the brain. For example, this memory for information, people, places, and things, is primarily located on the side of our brain, the medial temporal lobe near the temples, with a very famous area called the hippocampus that I'll get to a little bit later. But there's areas called the amygdala, the rhinal cortex that are involved as well. Procedures memory is related to the striatum. Associative learning, for example, can be related to the cerebellum or the amygdala, and so on and so forth. I want to focus on the hippocampus a bit because I think it's something that we probably pay attention to the most in terms of being worried about age-related cognitive changes and the short-term memory that associates with the hippocampus, the short-term memory for people, places, and things, for facts. So how do we know that the hippocampus is even involved? It's actually from a patient who became a volunteer. His initials were HM, and when he was a child, he had severe epilepsy that could not be controlled by medicine. And he had to have essentially a life-saving surgery where they removed a big chunk of his brain. And after that chunk of brain was removed, then he and his doctors and his family noted that he could not make short-term memories anymore. And he volunteered to be studied for the rest of his life. And what they found was that he had had his hippocampus removed. And that was how we knew that the hippocampus was important for short-term memory. Hippocampus is named as such because I believe it's from the Greek word for seahorse. And if you look at the shape of the hippocampus, it kind of does look like the seahorse. It's got the head and it's got the tail. Just so you know, the head is primarily for emotions, emotional memory, and motivational kind of memory, whereas the tail is mainly for facts. And then we actually focused even more on the hippocampus over the last several decades to look at the cell and molecular mechanisms of memory within that brain area. And what we found is that it's a chemical reaction between individual brain cells and the connections that mediate communications with those brain cells. So to the left is a slide of the hippocampus where all of the individual neurons, the brain cells of the hippocampal formation are green. And you can see how many there are in just that slice alone. There's a cartoon kind of zooming in on the individual connection between neurons called the synapse. And there was Nobel Prizes have been given for this work to show that that memory is essentially a strengthening of those connections that relates to molecular processes shown in the cartoon on the right. And so this wave that you see is sort of kind of representing the strength of the connection. And once this chemical reaction of memory forms, that connection between the two brain cells is stronger. So that's how our brain works, even beyond memory, even for other motor functions, etc. This is the currency of the brain, firing of brain cells that leads to changes in the strength of connections between brain cells. Okay, so now that we know a little bit about how the brain works and how memory works, let's talk about how the brain changes with aging and what to do about it. There are two broad uh, categories of, I would say, memory disorders. One is, you know, not being able to forget bad memories, and that's, for example, post-traumatic stress disorder. We're not going to talk about that. But, the other one that's relevant to aging is the losing the memories that you want, losing the good and important memories. And I think it's important when we think about pathologic brain aging like Alzheimer's and healthy brain aging is that the hippocampus is an organ, just like any other body. I mean, I think the brain, the hippocampus, we think of these as sort of black box kind of things where it's different from the heart or the kidney because so much of our personality, who we are, is really embedded in that organ. But we can't forget that it is like an organ just like any other one in the body. It has blood vessels that supply oxygen. It's made up of cells just like the other cells in the body that need nutrition, that need other metabolites to operate appropriately. And we know that in pathologic aging, there's a shrinkage of the brain that you can see to the right here in an Alzheimer's brain, and a buildup of those plaques and tangles that I showed before. Now remember, not all memory loss is Alzheimer's disease. There are a host of conditions that can influence various parts of this cognitive three-step process that relates to memory. For example, things like depression, anxiety, sleep issues, even metabolic issues like diabetes and endocrine problems can impact both the initial encoding of information as well as the retrieval. Diseases like Parkinson's disease and stroke-related disorders can also do the same. But when we're talking about true memory loss, meaning the eradication of the file cabinet, then we're talking about hippocampal damage. We're talking about Alzheimer's disease and other insults to that hippocampal structure itself, whether it be from trauma, focal strokes there, seizures that arise there, and a particular condition called hippocampal sclerosis. The other thing to realize is that not all memory loss is memory loss. Sometimes a patient or their family will tell us about memory loss, but when we dig deeper, we realize that it's not memory loss or memory and something else. For example, if you are poorly attentive for whatever reason, you're not going to be able to form the memories in the first place. If the person has an aphasia, which is an issue with producing language or understanding language, that may show up or be interpreted as a memory loss as well. If one is disorganized, cannot plan, that also can show up as a memory loss. So it's a part of our job is to distinguish among the concerns. Is this just memory, memory plus, or is it something else? And we can do that not only by asking questions, but some of the tests, diagnostic tests that we do, for example, the neuropsychological testing. And importantly, not all memory loss is abnormal. There is a gradual decline in cognitive abilities as we get older. And I'm going to represent these by very simple cartoon graphs, right? So if you plot age on the horizontal axis and the memory function itself, yeah, there's a subtle decline in memory that is accepted. When we do cognitive testing, we will often include age as a variable so that we can cut people slack because it's not fair to compare someone who's 50 versus someone who's 80. Um, what are the memory or cognitive issues with normal aging? I think there's some mild inconsistent trouble with words or names. Oftentimes I'll hear that it does come back with a little bit of a delay or with a bit of a hint. There's also trouble with multitasking. So if someone is in a situation where there are multiple things that they have to pay attention to, they're not going to remember properly. Or if they're asked to do too many things at once, they're going to have trouble kind of executing all of those things at the same time. But I think the key thing here is there really isn't any impact on someone's day-to-day function. Other examples of normal aging that I hear about are I went into a room and I forgot why I went in there. I had parked my car and it took me a lot longer to figure out where it was. I think those one-off incidents are okay. It's really what we get concerned about is consistent issues that really are affecting your ability to operate on your own. And typically when we do MRIs, for example, on folks with normal aging, their MRIs are usually fine. I mean, there's a little bit of shrinkage that happens with age. You can see that here's a normal older person. If you compare to a young person, yeah, there's a bit more shrinkage. These wrinkles of the brain are a little bit deeper, but it's not dramatic. And even radiologists will have their own way of sort of correcting for age. So what is the biology of normal aging? There must be something that's causing that gradual decline. So I quickly perused the literature last year to see yesterday if there was any, sort of summary, and it's complicated. I don't think we have a good handle of what is normal aging. I think as this cartoon suggests, there's genetic changes, there's changes to our mitochondria. Those are like the energy powerhouses of the cell. There's something called telomeres, which are the little caps on our chromosomes. They kind of shrink with age. There's a theory about that. The lysosomes are sort of the garbage can of the cell, and maybe they get a little bit inefficient as we get older. There's also cellular senescence, which is just cellular aging. And the other interesting concept is, well, normal aging may actually be a little bit of accumulation of these bad proteins, these toxic proteins of the diseases. It's just not to the extent that it causes brain degeneration, neuron degeneration. In fact, there's data showing that there's significant amyloid accumulation even in normal adults as early as age 50. So we can do amyloid scans, and we know from research studies that 10% of people at age 50, 15% at age 60, 20% of normal people at age 70, and 30% at age 80, and even up to 40% at age 90 have a significant amount of plaque buildup in their brain. Now, these folks are normal. They probably don't have a lot of tau and a lot of dysfunction, but maybe some of that slight downward line is from the amyloid alone. It's a theory. We don't know that, and we don't have any evidence to treat amyloid for that purpose as of yet. But I thought I would just, update you on where the science is on normal aging. Then we have things like mild cognitive impairment. This is when that line is starting to cross something that's a bit more consistent day to day. That person is still pretty independent, but it's measurable. You can take a test, clinical test, and we can see that it's declined. This impairment can also go beyond memory to include organization or language. And certainly this can be the very earliest stages of Alzheimer's disease. So unlike normal aging, now you probably have amyloid buildup, tau buildup, and some degeneration from those two toxic proteins. There are multiple biological causes of MCI, not just Alzheimer's disease, and some of those may actually be treatable, for example, depression and other things. And here we get a little bit more shrinkage in MCI, specifically if we're talking about the early stages of Alzheimer's disease. And then we have dementia. That's where this downward line is now crossing the threshold to be very consistent, impacting daily function. That person is depending more on others. It's noticeable by others. And there can be, of course, again, non-memory forms. Alzheimer's disease being the most common cause, although there's still other causes like Parkinson's and frontotemporal dementia, stroke, and vascular diseases that cause this. Some are still treatable, although they're rare. And here you'll get more drastic shrinkage of the brain. So you can see now 3 panels, the normal person who's older, the MCI patient who has a bit more shrinkage, and the mild Alzheimer's disease dementia patient who has even more shrinkage, in particular in the hippocampus. And if you can see, that white arrow is sort of indicating the hippocampus, because that seems to be the structure that's affected the earliest. Okay, so what do we do about it in terms of uh, protecting ourselves from Alzheimer's disease or optimizing ourselves for healthy brain aging? Well, I think that there are a lot of things that can be optimized in midlife, especially, and even in older age. You know, even at the beginning onset of the disease. So certainly, we want to look at depression, anxiety, mood issues, sleep issues, cardiovascular risk factors, um, diet, and so forth. And we'll get into these, but all of these things will impact the efficiency of each of these processes of this office analogy of memory. So another way to look at these modifiable factors, I group them as lifestyle, medical problems, and medications. And we'll go into each. Okay. So the modifiable risk factors include exercise, diet, socialization, and cognitive stimulation. So exercise, specifically aerobic exercise, the reason why we think it's good is that it increases blood flow to the hippocampus and other areas, right? Just remember, the brain is an organ. It may even help grow new neurons in the memory areas. It certainly improves your mood and sleep. And how much should we do? We don't really know. There are a lot of studies out there. I'm going to talk about one that was completed. It's unclear how much is the dose, but I would say at least getting 20 to 30 minutes a day of even light cardio, walking, is good. Diet-wise, I think the most famous diet that's been studied is the Mediterranean diet, and that's described in the pyramid to the right. I think the point here is that to consume lean protein sources, chicken, fish, using olive oil, eating greens and legumes like beans and lentils. There have been a lot of studies showing that it can lessen the shrinkage of the memory centers. And then, of course, the dietary advice will always also extend to eating salt in moderation, sugar as well, and having good vitamin B12 intake. Socialization is important because it can have an impact on the progression of cognitive decline. We know that when we socialize, our brain releases good chemicals for brain health, like serotonin and dopamine. It helps us to maintain our focus. And I think it helps us be oriented by having a social schedule. And lastly, cognitive stimulation. Um, what's my advice on that? I think people should do what you like. You know, if you like to play cars, like the gentleman in this picture, do that. Try different variations of that. Try a new card game, for example. I think doing new things is always better. Trying a variety of things is better as well. It's always better when coupled with socializing. And I think it helps our brain develop new strategies in the face of age-related changes, in the face of pathologic changes. I wanted to highlight a study that came out this summer. It was a big newsworthy item at our conference over the summer, and it was the results of the U.S. Pointer study. Um, it was heavily sponsored by the Alzheimer's Association, and it was published in the journal JAMA, and you all can take a look at that paper. But it is, one issue with this whole lifestyle uh, area is that it's been very difficult to get strong evidence that it helps, and also to when does it help. And just to preface this, you know, I think the more we've learned about this field, the more we've realized that we have to start earlier and earlier and earlier. We know that once the wheels of Alzheimer's disease and related dementias begin, it's very hard to stop them from progressing, even with a lot of lifestyle changes. Of course, it can help a little bit, but this is a pathologic process. And so we're trying to look earlier and earlier. Can we give advice to people in in their middle age, before the onset of these diseases? And so, what is that advice, and what evidence is there? So this was probably the biggest lifestyle study that's ever been conducted, actually comparing two different methodologies. So this is a trial of over 2,000 older adults who are normal, but who were at risk for cognitive decline and dementia. For example, they had a genetic risk factor, or they had a strong family history, or other risk factors. And this was a 2-year study, and half the participants had a very structured, intense lifestyle intervention, and the other group underwent a lower intensity, self-guided intervention. And that US pointer intervention is in the cartoon to the right. And I'll go over it in a second. What they found was that it did actually have a benefit, that was significantly greater for the participants in the structured intervention group. So both groups did improve a little bit with their cognition, but the impacts were even more with the group that got the structured one. And so these positive results really underscore that healthy behavior has a powerful impact on brain health. And what their recipe was a combination of physical exercise. So this was 30 to 35 minutes of moderate, intense aerobic activity 4 times a week, plus strength and flexibility exercises twice a week. There was cognitive exercise. So 3 times a week for 30 minutes, there was a computer-based program, plus engagement in other intellectually challenging activities. There were regular check-ins for blood pressure, weight, and labs. And there was nutritional guidance, emphasizing the mind diet, which is very similar to the Mediterranean diet, essentially. It might just may allow wine. I think that's one of the major differences. But the Alzheimer's Association website has also information about the Pointer study. I think it has information about their brain health recipe that you all can look at. Now, this is the initial study. I think that there's a lot more that we need to figure out. How generalizable is this? How is this actually working? Did they actually see changes? Would we actually see changes in blood markers for Alzheimer's disease, for example? Would we actually see less shrinkage of the brain with longer periods of intervention? I think that there are a lot more questions that need to be answered, but I think this is the first step. So what dovetails from this are other modifiable risk factors that sort of tie into these lifestyle issues. For example, insomnia, sleep apnea. They can couple with mood and exercise, right? You have blood pressure, cholesterol, glucose control, B12 levels. Those tie into diet and exercise. Um, Mood plays a big role in cognitive health, depression, anxiety. Then you have endocrine issues, inflammation, and sensory problems. And the sensory problems can tie into cognitive stimulation as well. So I'm going to talk a little bit about some of these that are somewhat newer. So in terms of inflammation, that's become a really hot topic. We now do strongly feel that the immune system, the inflammatory response, has a great influence on Alzheimer's disease risk and even healthy brain aging. And so looking for sources of negative inflammation in the body and trying to mitigate that will be very important. So one aspect that has been studied is dental hygiene. We know that overgrowth of certain bacteria can be associated with cognitive decline and Alzheimer's disease. And so, I think it's always encouraged to continue to promote good dental care, oral health as we get older. We know that good oral health also promotes good general health, and it helps establish day and night routines, even for those people who are having overt dementia. In terms of sensory problems, I think one topic that's become very hot lately is hearing. So obviously you can't remember what if you're not hearing, and it impacts our ability to socially engage and be cognitively stimulated. But what's interesting is that hearing information, the auditory information, actually goes to the same area where memory is processed. So that hippocampus area, which is in the temporal lobe, is exactly where the ears give their inputs to. And I think that that temporal lobe likes that input. And so when you have hearing impairment, those areas are going to shrink because they're not getting that stimulation. And there's been data showing that people who wear their hearing aids versus those that don't have less cognitive decline with age. Another aspect of this is are the medications that us doctors give. So this is something called polypharmacy. I think that as people get older, they start to accumulate, unfortunately, longer medication lists. And I think it's really important to review your medication list with your primary doctor to make sure you're on the right ones and then you're taking them the right way. So I always encourage people to bring in their bottles. It's important to discuss medications that may impact memory and thinking. And these are called the anticholinergic medications. These include antihistamines, some neurological meds, some antidepressants. Opiates can also impact cognition, like the pain medications, and benzodiazepines. For example, clonazepam, anything with the PAM at the end of it, diazepam. These are benzodiazepines that can also negatively impact thinking. So it's good to discuss these with your primary doctor, make sure that they're appropriate, that you're appropriately taking them. If you don't need them, what's the best way to find other options or wean off? So that's an important discussion to have with your primary doctor or geriatrician. And lastly, there are a lot of herbals and supplements that people take nowadays, and I don't have any problem with those personally. I just like to know what my patients are taking. I do like to look them up myself. There are some that we know enough about to say that they're okay, and there's some that we know enough about to say, well, I think that this is not a good idea because it's conflicting with this other medicine. So I think it's always important to let your physicians know about what herbals and supplements you're taking as well. So, what are my take-home points? Well, memory is a multi-step biological process in the brain that is impacted by other forms of cognition and thinking. Remember that memory and other cognitive decline doesn't necessarily mean Alzheimer's and dementia. There are other conditions and modifiable factors that can play a big role. And that modifiable factors relate to lifestyle, medical conditions, and medications. And so I wanted to stop with enough time to uh, take questions.